We're going to move. We're going to move fairly fast. We're back in your manual. If you go to, I think, page 4, and we're going to go pick up from page 4. I'm going to pick up the pace a little bit because I think we've covered most of the spirit of flat thoracic spines, flat diaphragms, the roundedness that's needed. We touched based on extension, touched based on extension. And if I go too fast now, all you got to do is just raise your hand up. But I'm going to show you pictures. I'm just going to show you pictures clinically to solidify what we've already discussed. If I see something new that I think is important for us to, at that point, to cover a little bit more slowly, I will. Or you've got to do that. Otherwise, the course attendee at home has got their manual. They'll have this nice description of what you're seeing, and they can go slow at their own pace, which you don't have that luxury of doing. So you got to stop. Otherwise, you'll get left in the dust. On page 4 or 5, we talk about this thoracic concavity issue. It is a huge problem with people who cannot achieve full appreciation for their arms. Again, this is a course that's going to talk about the rib cage, shoulder blade, and arms. And so when you have difficulties with your arms, like this lady had, you do extreme issues. She had such heavy arms. Does she look like a heavy lady to you? She had such heavy arms in her mind that she had her breasts removed, both of them. They go to extreme issues. But what really she has a pectus like this lady does. The arms are forward, they're heavy, they're weighing on their neck, and they get, you know how this is, it's tough. So this lady here, and there's a bunch of pictures coming up, they're all, see the similarities? We see POTS patients these days that have very, Heidi, you see the similarity, Heidi? Pelvises that are a little bit enlarged, lack of control of the inlet and the outlet, poor frontal plane control through their abdomen and their thorax and their inlet and their outlet, and then these striated, really stable, overstable spines without enough what in their life? Rib rotation. We see that a lot clinically. I think this course has taken on a little bit of a different appreciation for it, because if you took it 12 years ago or 10 years ago, we would have talked about ventilatory activity, but now here we are 10 years later, Gail, and I'm seeing clinically it's true. Research was right. If you have a pectus, you're probably restricted in rotational activities from the ribs themselves, and that's what these women are demonstrating. And they go to extreme measures. I mean, this particular lady was a patient of mine, and she's had her neck injected. She's even had Botox to her upper traps, and you see the abdominal protrusion and the forward shoulders and the straight up and down sternocleidomastoid. But that's a pectus. They lay there and they've got these pectuses, and unfortunately, what's really, if you just look at the picture, just look at the slide. Stephanie, just look at it. What is that human being telling you right there? Just look at her. Frontal view. Not a frontal view, but a frontal plane view, because you're seeing from the side. What is she saying to us? I can't breathe. I just can't expand. I push contents down my pelvis. I push contents forward. I can't expand. That's what she's saying to you. I have to pull to get my air in. I have to extend my back to get it out. That's what she's saying to you. My ribs are up. My pecs are active. My pecs are inhalers. My pecs are exhalers. My shoulders are forward. You know this. You had both your pecs what? Transferred. Moved. I mean, this is a lady that can tell you all about. She could give this course, right? Yeah. You could give this course. So far, have you seen about everything on this discussion this year? These are real people. And the biggest issue is there's a little bit of that going on in everybody. So I'm going to tell you, that's not, to me, that's a pectus, but it's not a pectus. It is a pectus, but it's really not. It's a person who can't what? Breathe. They have really, really flat backs, very flat backs. I used to do things in my earlier years. I remember some mentors of mine that I really got a lot. Sandy Burkhart was so good to me. I've got some really good mentors, but unfortunately we were looking at shoulder blades. We weren't looking at thoraxes. I've grown up to look at thoraxes because before you put a hand under here to get a shoulder blade to move, you better make sure the thorax is there for you to sit back onto. They are very strained individuals. The serratus anterior function is off. The lower trap is really struggling to keep and maintain rib cage function, which we'll talk about. So you'll see a lot of hypermobility, a lot of serratus dysfunction, a lot of subscapularis misplacement and mistreatment and misguidedness. You'll see internal rotation provided by a pec minor and a lat, when that internal rotation should be provided by a muscle that's underneath that scapula called the what is it? Subscapularis. So if you don't have a subscapularis that's internally rotating a humeral bone, you've got other things that come to the rescue or did it for you, which is why you lost it. So anyway, I'm going kind of fast. Flat back. She's got 2 rods on each side of her spine, and she's had surgery. But really, there's whether you're rotted or not rotted, these people are the same. Either you rod yourself, or you have somebody do it for you. Stephanie works, gives me the stability I need. So she's a lordotic person with a forward head, and really there's no difference between her and this lady. And the only difference is that she's got a rod from probably C5 all the way down to L4. See a lot of nurses in my life. I love nurses. This woman was so appreciative, but she did not want her body exposed, so she left the t-shirt on. That is not her breast. That's her chest. So she looks like she has breast tissue there. It's not. She has her breast, but the ribs are so high that she didn't even want to take her t-shirt off and show you with a sports bra on. Look at her shirt drape. No glutes. Genuine recurvatum. I get shoe boxes of these. This is before the day and age where we had iPhones. So, these are not digital pictures. But I love these pictures because these people are real. They exist. They are still walking around. They get older. Love to see this lady again. I don't know where she's at. That's a 25-year-old picture. This is another picture of a dental assistant, flat back. Flat backs have been my nemesis. The Institute exists because of flat backs. Did you hear what I just said? We wouldn't be here if it wasn't for those flat backs. Because for years I've been thinking, Stephanie, who am I going to talk to that's going to finally talk to me about a flat back? Not kyphosis, not lordosis, not argue with me about extension. Just tell me who looks at backs that are what? Flat. We have good occupations out there that talk about reversal of the cervical spine. But talk to me about a flat back. You know where I found that information? From journals that did something with FEV1s. You know what FEV1s are? The way you breathe in 1 second. Pulmonary tests that say you can't breathe. That's where I saw flat backs. It's a big jump, isn't it? That's a big ocean to crawl over. There's a correlation between poor FEV1s and flat backs, and the answer is objectively, scientifically, evidence-based wise, absolutely. So, orthopedically wise, if you think about what we're going with this, the message is you got to keep that back in an unextended state, again, with a respiratory system that's not in a position to work like it should. It's another nurse, a very flat back. I used to do this all the time. It brings back memories, good memories. All these people, by the way, also did very well. They did very well with wall reaches back then. They did very well with reciprocal work that was retro. I retrofitted them. They walked backwards. They found heels. They knew how to move knees forward as the butt goes what? Back. Posterior pelvic tilt had a different meaning back then. You did posterior pelvic tilt not because you had an SI problem. You did posterior pelvic tilt to make sure that the hip flexors could shut off. That's called hip extension. I don't know why we never captured that moment, but we never did. I don't know when we will, Rick, but it's been a while. I don't know if it'll ever happen. So that's a flat back. That's a flat back. Tons of these. They're old pictures. I don't want them dropping them off, Jen, because I want the history to tell you these people are walking around to this day with what? Flat backs. Start looking for them. Look at your kids. It's the paralegal secretary. Flat back. No glutes. Before you tell me she has no glutes, tell me why she has no glutes. Don't tell me she has no glutes. That's obvious. How about this? She has no glutes. She has a posterior tibial tendon that's overworking. She has no IOs and TAs. I can keep going. Why are you picking on the glutes? Do you understand? I can keep going with you. The problem is she has none of that because she doesn't know how to breathe. She's extended. And that's okay. I guess we let that go, but we shouldn't. So not on my soapbox. I'm showing you pictures of what they used to look like. They did very well. That is a flat back. Now, this is a mother of 3 kids. You know, back then she was doing great. She's I think this is a paralegal secretary, and she was doing good. And the person that got her in was her boss, an attorney that was my wife's boss. Please go see Ron. Do something about your nagging tension. She did very well. I mean, look at the flatness of that back. Can you say flatness of a diaphragm? You know, that's what she had going on as she was sitting there every day. This is a lady who's a first grade teacher. She was diagnosed with thoracic outlet symptoms. She had thoracic spine pain. She had a history of a right scapula that's constantly snapped on her. She worked in a meatpacking plant in Schuyler, Nebraska. She had that since 1995. She had physical therapy on and off for the past 8 years. PT did a great job with her. She went to see an orthopedic doctor and said, you know, I've been seeing this physical therapist for 7 to 8 years. It's still snapping. I got to keep my job. That's my only income. I got to keep it. Doc said, okay, well, that's fine. We'll just cut off the superior angle of your scapula, and we'll see if that helps you. So she had her superior angle of her scapula cut off, and now she is not employed. She had no. Remember the angle of the scapula. What goes on that angle? A thing called the tricep. We're going to talk about the tricep a little bit. One head of it, but she had the whole superior angle of that spine, scapula. We have one tricep over it. We removed all of it and angled it off, buffed it off, smoothed it out. Now she's got a teeny little scapula on the right side, and she doesn't snap anymore. But her arm's dead. You know, she can't function. So that's a true story. So now you understand why my passion is there. Do you guys understand? Now you understand I don't just sit around and dream this stuff up. This has been going on for years. It's going on in your hometown. You don't even see it until you start looking for it. So overdevelopment of pecs. Pecs are not nice. They're pesky. Okay? I work with the volleyball team. We got a great team. It's going to be a super team in the next few years. They got pesky pecs. Okay? And we're all over these pecs now because they're well-built women with overdeveloped pecs. They may be doing some great stuff out there, but their pecs are too what? Overdeveloped. You can develop a pec, but make sure you got ribs underneath of it that are what? Moving. So, pesky pecs. That's a pesky pec. He's an architect. A poor guy, again, his rectus is up, and his biggest problem is not his neck tension. His biggest problem is he doesn't know how to let his chest expand because the pecs are keeping it what, Stephanie? Tight. His pecs are too tight. We have a pec program, a pec technique. A pec technique is not going to help anybody if the ribs are not rotating, alternating, moving, like we talked about earlier. Right rotation on left AFIR, left rotation on right AFIR, which is the same thing as stance. So he has no glutes. Don't pick on his glutes. Don't pick on his abs. Don't pick on anything. How about this? This man can't breathe because he has pesky pecs. Okay? They're too what, Chad? They're too active. He's taking that draft table every day, stabilizing it and working his body, stabilizing his body with his pecs for distal fine motor control. They're very motor cortically active for him to draw precisely very symmetrical letters and numbers thousands of times a week. Okay? He doesn't need a ruler to make a straight line. He has a pec that'll do it. Does that make sense to you guys? I don't know if it does, but